This is a discussion about health insurance and healthcare costs. We'll talk about what health insurance is, how much does it cost, who pays it, and who uses it. From there, we'll move on to the issue of how can we control healthcare costs. A discussion of employer healthcare. First, we look at the cost of healthcare and insurance. Healthcare costs are increasing at 3 to 4 times the rate of inflation. Most healthcare is not covered by the government, but it's covered by employer insurance. Typically, employers hold down their insurance costs by looking for competitive insurance rates, but more importantly, by dropping coverage for some employees, limiting enrollment, increasing copays and deductibles, and requiring employees to pay part of the cost of the premium. All of this employer cost cutting usually shifts the cost to employees at a rate that's higher than inflation. After looking at insurance, we need to discuss what makes up healthcare costs as opposed to insurance. We're going to look at the 4 components of healthcare costs, including drugs, physicians, hospitals, and insurance and administrative costs. Finally, we're going to look at what employers can do to hold down healthcare costs. These include strategies that employees and employers can take together that would help to drive down the cost of all the components at our regional level. Part 1, how high can costs go and who pays for health care? This slide indicates that in 2009, healthcare amounted to 17.3% of gross domestic product. That means $17 out of every $100 that's spent in this country was used for healthcare. And that climbed by over 1 point per year from 2008 to 2009. Perhaps more frightening is the projection of the Council of Economic Advisors that projects that by the year 2040, healthcare will consume 33% of all dollars, all wealth in the country. So who pays for healthcare? Insurance reimbursements are 36%, and that includes an additional 15% from private payments and 4% from private donations, for a total of roughly 55%. Federal and state governments, primarily through Medicare and Medicaid programs, as well as direct benefit programs like TRICARE, account for 45%. The percent of the population that's insured is 84%, and of that, 59% is paid for by employers. Employers make up the largest share of payments that go into the healthcare system. Governments and individuals together only amount to about 37%. This diagram shows this graphically, and the large blue part of the pie to the right is employer-sponsored health insurance. So how many employers actually pay premiums for their employees? Well, in 2010 it was about 60%, but in 2000 it was 69%, a drop of 9% over a 10-year period. And what do employees pay? Well, in 2006, employees contributed about 16% of their premium and about 28% of the family premium. And that's over and above what they paid for deductibles and copays. One of the things we noted was that employer insurance dropped by 9% over the 10-year period. Large firms, most of them, pay health insurance. 96% of the firms with 50 or more employees offer health insurance. Small firms with fewer than 50 workers, only 43% of the firms offered health insurance. And that's dropping on an annual basis. And the Council of Economic Advisors projects that by the year 2040, that 43% of small firms will drop down to 20%, or half of the small firms that currently offer it will drop it. Beyond whether health care is offered or not, employers are also shifting costs. They're shifting costs by increasing deductibles. If you look at these diagrams, on the left you have small employers with fewer than 50 employees. And between 1999 and 2006, the cost of deductibles, that part that the employee has to pay, went up from roughly $1,200–$1,300 a year up to $2,000 a year, an increase of about 50%. Firms with 50 or more employees went from roughly $800 a year up to $1,200. A smaller increase, but nonetheless an increase. This meant that more of the health care costs were being passed on to the employees. So what was going on in the real world in terms of wages and inflation? From 2001 to 2006, wages increased by 19%, inflation increased by 17%. Health insurance, on the other hand, increased 78% during that same 5-year period. 78% versus 19% for wages, nearly 4 times as fast. On the 10-year period from 2001 to 2011, the rate for health insurance premiums increased 113%. Not only is health insurance going up, but the growth in family costs for health care went up. They doubled between 2002 and 2011, from $9,000 to $19,000. Part 2 discusses what makes up health care costs as opposed to insurance costs, and what drives those costs up. This chart shows how all of our healthcare dollars are spent. This includes health care provided by military services, private employers with clinics in their own facilities, as well as all public care. On this chart, which includes all costs, 31% is hospital care, 21% is physicians, 10% is drugs, home health, nursing home care is 8%, administrative and net costs, which includes insurance costs, is 7%, and all other is 22%. And other includes medical care provided by private employers directly for their employers at the work site, as well as government spending for medical care and the services, usually in schools, military stations, and community centers. So what's happened in 3 of those areas? Over the last 10 years, drug price growth was 89% increased. Hospitalization went up 67%, and physicians went up 66%. And compare that with the cost of insurance. Over that same 10-year period, insurance went up 113%. That meant that the rate for insurance increased dramatically more than what was actually the cost of providing those same services for drugs, hospitalization, and physicians. What factors increase healthcare costs? This is a discussion of 4 different views: the private business view, the insurance company view, the government healthcare provider view as recognized by the Medicare and Medicaid system, and the federal executive view that ended up in the legislation known as the Affordable Care Act. All of these views were obtained by looking at public documents online. The private business view is taken from the Cato Handbook for Policymakers, and it says that the biggest concerns for business are to shift the cost of health care away from employers to the employees, to get more competition in the system to reduce the cost of insurance contracts, to avoid medical tort claims through voluntary contracts, and to shift the cost of unfunded health care to the government and away from health care providers being passed on to insurance companies. Insurance company view is that they're in business to sell products, and they want the right to sell any product that any person wants to buy, including products which may have higher deductibles, higher co-pays, less coverage. Those are things which many consumers are looking to buy. These statements were taken from Dr. Donald Berwick, who is the former director of the Centers for Medicare and Medicaid Services for the federal government after he retired. He listed the 5 causes for increases in health care spending: over-treatment of patients, the failure to coordinate care, the administrative complexity of the system, burdensome rules, and fraud. The executive view throughout that's part of the Obamacare system is that the payment for health care ought to be based on rewarding health as opposed to the number of specific services offered. The second tenet is that there has to be choice. The third tenet is that the costs have to be borne by everybody as closely as possible. That means covering all people in the system, whether they're working for employers with health insurance or not. And finally, recognizing that some people are not going to be able to pay for health care because their wages do not allow that, to increase revenue to cover those people through income tax, penalties, new additional premiums. And finally, to increase restrictions on premiums and policies so that the deductibles, co-pays, denials, and appeals rights are guaranteed in the new coverage. This lengthy list was taken from Wikipedia, the home page where it discusses what makes up healthcare costs. It's a nice statement indicating all the various cost elements that are in the system. So how do we currently control costs as employers? And which costs? Well, one of the things we do in the municipal side, in schools, and some nonprofits is to self-insure through pools. So we bundle all of our risks together into large pools. In this state, there are 3 pools. There's a local government center pool, a school care pool, and the Hampshire Insurance Trust. As employers, we tend to play those pools off against each other to get the best rates. Beyond what we do with the insurance pools, we limit who's eligible. So for instance, we may limit how much we're going to do for spouses or families. We may limit how much we're going to offer new hires that come into the system. We may hire part-time employees. Or we may increase the amount of the cost that the employees have to be picking up from the total premium cost. Finally, we increase the deductibles that have to be paid directly by the employee and require higher co-pays. In short, we don't manage healthcare costs. We shift the cost to others. We look for competition between the insurance pools to shift our cost to somebody that's willing to give us a better price. We restrict the people we cover by shifting the cost of the care to our employees who don't meet the conditions we impose. We make the employees pay a higher part of the premium cost, again shifting the cost. We increase the deductibles and co-pays, again shifting the costs. We don't manage actual health care costs, we merely shift them. How do pools function? Well, basically, a large group of employers get together and create risk tables, actuarial tables, on the whole pool to project the costs for a single or multi-year schedule. This creation of a very large pool means that you've got a more reasonable rate that you're paying for actual coverage that isn't restricted to what you have in your own individual community. Quotes are requested of the insurance providers for the anticipated level of service and for managing the customer service. So the pools don't actually manage customer service, they hire an insurance company to do it. They also expect the insurance company to do cost containment. And the way they obtain that is by getting rate proposals from the various providers. To hold down costs, pools do maintain an independent reserve fund to cover excess claims during the scheduled term, so that part of the cost is shifted back to the employers by having their own reserve fund. So what do the pools do to control healthcare costs? They encourage healthy living, they stress preventive care, they look for the most favorable modeling of the risks, they urge insurance companies to question unnecessary services or use companies that already manage services to cut costs, and the pools also reinsure to protect themselves for extraordinary losses. One of the issues comes up is when insurance companies are managing costs, is how do the pools know that they're actually receiving the benefits of those cost savings? And the answer is most of the pools that we've had discussions with really have no concrete or specific information to say this much money was saved over what the expectation was, and therefore you're getting this money back. Usually the answer from the insurance companies is it's factored into the rates we're proposing for you. So what can employers really do to control health costs? So what healthcare costs can we control? Cost of drugs, that's on an employee-by-employee basis. Cost of primary care, usually local care. The cost of administration, which includes insurance costs, and fraud. Each of the percentages shown here is that part of the health insurance cost that covers that particular element. So 14% of our cost is drugs, 30% is primary care, and 10% is administration and insurance costs. One of the things that can be done is to control pharmaceutical costs by bundling the purchases into very large purchases that are nationwide purchases and get the lowest possible price for the drugs. Very often, insurance companies will use this system by requiring or reducing the cost if you purchase the drugs directly from the insurance company. The actual savings by doing that type of a bid process without the insurance company is 75% of the cost. That's what the national average is for bundling the purchase of drugs and getting the lowest possible bid for the drugs nationwide. A 75% reduction in cost. There are a variety of ways of doing it. Some facilities do get very inexpensive, low-cost pricing on their drugs and pass those on to their customers. In every case, customers and payers can use a system like this one, BidRx, to bid out the drugs on a quarterly basis and reduce the cost by roughly 75%. The second category is how can we control primary care cost? Well, the blue notes here indicate the various pieces of cost: physician cost, support staff cost, equipment and building utilization, and to a lesser extent, record transmission and communication to make sure we're not providing redundant services or services in conflict with each other. One of the major pieces in addition to cost is quality of service. Cost containment without quality service doesn't work. Both things have to be accomplished at the same time. The ways we can manage primary care costs is to, again, pay for service that ends up with healthy outcomes for all patients. We can look to reduce the cost by using economies of scale, using larger facilities to have more services that are included in the primary care system to keep the costs at the lowest possible price as opposed to moving more of those costs into an acute care facility. This is called holding the primary care system accountable for both costs and quality. Beyond that, we can reduce litigation expenses and liability claims by looking for voluntary controls on the ability to sue for anything other than gross or intentional negligence. By creating primary care facilities which are very competitive in terms of cost as well as care, we can create more competition in the primary care system, even if people aren't participating in a primary care system that does offer that, because other primary care providers will be forced to compete. Finally, a system like that can manage the cost for all patients, those that are insured and uninsured, by using a single system where the costs are managed for everybody. This is an example of that type of facility. In current language, these types of facilities that are accountable both in terms of quality of care and efficiency and cost are designated as federally qualified health clinics. This is an example of one in Vermont, and we could try to structure our primary care system in the Upper Valley in a similar way. In a primary care system such as this, it's no different than a regular primary care system. and the docs would have privileges at all local hospitals. And it wouldn't affect what happens for hospital coverage or specialists or out-of-region coverage. That would still be treated the way it always has been. This focuses on primary care, the person that you see on a regular basis for checkups and for diagnostics. And there would still be choice in this system. People could choose whether they use this system or use a different system, but this system would provide extremely advantageous costs. This system is located in Plainfield, Vermont. It's called the Health Center. As on a personal note, I started this health center in Vermont back in 1973. It currently is still going strong and has 14,000 patients. So what is it? 6 rural towns got together back in 1975 and created a community board of directors and formed a nonprofit corporation to offer community health. It was designed to service all the people in the town from all income levels, from people who had no insurance nor ability to pay, to people who were well off, wealthy, as well as people who were covered by insurance plans. It was dedicated to quality service. It initially offered primary care, lab, x-ray, counseling, pharmacy, and education. These 2 or 3 slides talk about the history of the health center. Being a community health center and struggling to cover all the people in the community, both rich and poor, and still offer quality service, was a challenge for the first 20 years of its existence. They had a struggle for every dollar that went into the system and make sure that the facility was run economically and still covered the entire population. To assure that, there was a community board of directors. The board then, as it is now, was composed primarily of people elected on town meeting day, although not through the town governments, but elected at town meeting day to serve on the board. And 50% of those people were up for election every year. There were 12 people from the 6 towns, 2 representatives from each town. An additional 5 people served on the board who were the professionals working in the system. As we noted, it was always difficult to run the system at the beginning. Throughout the early years of the system, every person that was underinsured or uninsured represented a loss to the clinic, and that was on Medicare and Medicaid office visits and services. One of the things that the clinic used was a sliding scale system to make sure all the people who were unfunded paid something for their care. And they did this for over 30 years. They were able to maintain the control of the facility, offer quality services, take and provide care to every person in the community, whether they're insured or not. But they did have to run it as a lean primary care center. In 2010, the health center became a federally qualified health center. And what that meant was that they got higher reimbursements for their Medicare and Medicaid visits. And that was because they had proven to be able to do 2 things: keep their costs very reasonable and keep their quality very high. The result was that the amount that they received from Medicare and Medicaid went up dramatically. From 2009, when they had 9,400 patients, to current, they expanded their patient base from 9,400 patients to 14,000 patients, all through the use of these additional funds. This is what's currently offered, or this is what was offered actually in 2009 when they had 9,400 patients. We used 2009 as a benchmark because that was before they became a federally qualified health center. They were open 60 hours a week, offering primary care that included both doctors and nurse practitioners. They had 9 dental chairs in the clinic for dental work, plus a mobile dental service that went directly to the schools or nursing homes or extended care facilities. They had a low-cost nonprofit pharmacy that was incorporated in the clinic that also had automatic dispensing. They provided psychiatric counseling to patients as well as to the schools in the area. They provided physical therapy and lab and x-ray services. And they offered community transportation so that anybody that needed a ride to the clinic could get the ride. In 2009, they had 47 full-time employees and 36 part-time employees. This is their tax return from 2009. If you look in the right-hand column, down around line 18, you'll see that in 2009, they spent $5,951,000. Roughly $6 million was spent. If you look above on line 12 in the right-hand column, you'll see that they took in nearly $7 million in revenue. $7 million in revenue, $6 million in expenses. So for the year 2009, they actually made nearly $1 million, which went into the reserve accounts. So at the time when many other facilities are trying to take care of low-income and poor people and losing so much money that they go into the red, this facility actually cleared $1 million out of $7 million that came in revenue. On this slide, you can look at what makes up their expenses. Again, the left-hand column is the expenses for the year 2009. And you'll see that the total expenses at the bottom were $6 million. There are some interesting things about this sheet. The first one is under line 24B. It's towards the bottom, and it says bad debts. And you'll see that in the bad debts column, out of a $7 million revenue and $6 million expense, they only had $59,000 in bad debts. A very small number. 10% would have been $600,000. This is about 1% for bad debts. Another major change is on line 23, where you see the cost of their malpractice insurance. $72,000, roughly 1% of the gross revenue. 1% of gross revenue. The industry standard for primary care facilities is 7% of gross revenue. So for most primary care facilities, the cost of malpractice insurance is $490,000 a year for a facility this size. This one's only $70,000. Why? Because they offer quality care and because the community is absolutely dedicated to their healthcare system. Other issues that are interesting, their debt service in the form of the interest payments they make in line 20 is very small. It's only about 1.5% of the total budget, $108,000. The lion's share of the cost is in salaries, wages, and employee benefits. So let's look at the wages. This is a very telling slide. This is again from their tax return. The 12 people at the top over on the left-hand side are all directors and officers of the corporation, and all of them reside within the 6 towns, and all of them are elected by the communities that they come from. And you'll see that there's zero compensation. That's the third column from the right. Zero compensation all the way through for the first 12 people. The last 6 people are paid members of the board. The medical director is John Matthew. He's the first one with a wage, and his wage is $214,000 a year. John was originally one of the creators of the clinic back in 1975. So basically, for a total of 35 years worth of work in this clinic, his wage had grown to $214,000. The finance director is Claudia Leobold, $116,000, who is responsible for managing the corporation in terms of all its financial efforts and revenue streams coming in from patient visits and federal and insurance programs. The other 3 people are all professionals in the system, doctors and dentists. If you look at their wages, the low is $129,000 a year, the high is $189,000 a year. The industry standard in New Hampshire is $180,000 for a primary care physician. If you look at this, you'll see that the average here is about $140,000. to $150,000. That's a reduction of $30,000 a year. So why is it people are willing to do that? Why are they willing to work for less money? And part of the answer is because of the nature of the practice. They're able to deal with community people that they see on a regular basis in the community. They're able to deal with all of the issues that they have that are healthcare issues. They're able to deal with the person as a whole person and at the same location with people that are working side by side with them, offer psychiatric services, physical therapy services, obtain lab and x-ray services, and provide medications. It's a much more comprehensive service where more time is spent with the patient to make sure that the patient remains healthy. This is a summary of that clinic. 2009, before they got increased federal funding. They had 9,400 patients. The total cost was $6 million. The annual per patient cost for service for primary care, dental care, lab, x-ray, and drugs was $633 a year. Typically, we spend for a family of four $8,000 a year in our insurance premiums for primary care. That works out to $2,000 per patient. This cost is $633, or roughly one-third of what we currently pay. Interestingly enough, at this clinic, beyond the $633, on the rate structure they had, they also got an average of $91 per patient that was received in payments that went into the reserve accounts for this clinic. So how can we control administrative costs? The first step is to pay for outcomes rather than specific functions. So rather than paying for multiple x-rays and lab services and examinations, we're paying for healthy people. The second thing we can do is to make sure that there truly is coordination of record keeping between all players in the healthcare system to reduce mistakes, to reduce redundant services, and to make sure that the healthcare is appropriate for the person. Finally, we reduce the number of providers. That means not necessarily getting rid of doctors. It means that we're going to be providing services to more people, but in a way that's more efficient. Doing it that way means that we're reducing duplication of efforts, duplication of facilities, and inconsistent information. We're still using the same number of doctors, but more people are being served in a better manner. How can we control insurance costs? The federal program looks to spread the risk over more people. One of the things we can do immediately is to spread our risk over a longer period. Rather than looking at the current ages of our employees today, or over the next 2 or 3 years, we can look at the potential and actual ages of our employees over a 5-year period. And by doing that, we can create a larger period that's covered under the risk assessment. Brings in newer people as well as older people, but spreads the risk over a longer period of time. By doing that, one of the other advantages is that we can arbitrage earnings. If we're going to fund a program over a 5-year cycle with increases built in for the cost of living, it's front-end loaded. And by front-end loading it, there is a way that we can make money on the monies that we set aside now for 5 years from now. One thing we can do is to take more active management of fraud to make sure people are not abusing the system. We can also work for voluntary limitations on negligence claims that are not intentional nor gross negligence. Finally, we tried to tailor our efforts to reduce costs to make sure that those cost reductions and cost containment activities actually help us in terms of what we pay and in terms of the services we receive. This series of slides shows one company that specializes in doing long-term trust agreements and funding of healthcare programs over 5 and 10 years. I'm not going to spend a great deal of time discussing it other than to show that they do exist. There is a way to create larger or longer periods of time for risk assessment with resulting reduction in rates as well as arbitraging the money over a longer period of time, anywhere from 1/2 to 3% net income on the money. So we've looked at drugs, we've looked at insurance costs, we've looked at primary care. So what are our long-term goals? Rather than saying we're going to cut costs, what we're really saying is we need to stabilize costs. Remember that costs were increasing at 3 to 4 times the rate of inflation. The goal is to have cost stability. It should track with inflation, or no more than twice the rate of inflation, which would significantly hold down our costs going forward. We're looking for competitive customer service. If it doesn't exist, we need to create it. We're looking to maintain multiple plan levels for copays and deductibles because that's what exists in the marketplace now. But we are also looking for consumer responsibility and consumer choice. So for as an example, if somebody wants to go to a primary care facility that is cost effective and offers quality service, their obligation to make a copay for that service ought to be nominal or non-existent. Whereas if they go to a primary care facility where there is no cost containment, then the copay ought to be dramatically higher. How much higher? It might very well cost them $50 to $75 for a doctor's visit if that doctor is not engaging in any type of efficiency practices. Whereas it might be nothing if they go to a primary care facility where there is cost containment. Encouraging cost containment and full utilization and coordination means that we can cut our costs. Or again, to better define what that means, we can divert the money we would use for multiple services into future needs in the medical care system. We can do the same thing by reducing defensive medicine costs and by getting lower malpractice insurance costs. What are our objectives from those goals? First thing is to make sure that we have enough leverage and bargaining power to get 75% of all the employer plans engaged in active cost containment programs with the providers themselves on an equal basis. From that, to reduce our drug costs by 60%. Get the lowest cost possible for insurance, customer service, and rate setting. Share control and funding of the regional primary care. We already pay for it. Let's make sure it's efficient and effective. The most efficient system is roughly one system for every 10,000 patients. Our expectation is that the cost for that service would not be more than $1,000 per person per year, or a savings of 50% over what we currently pay. That money could be used to make sure that acute care facilities are adequately funded. Customer incentives. We can build in customer incentives to ensure that people have choice, but they understand what the cost of their choices are. And if they choose to use inefficient systems or systems that are not effective, that they're going to pay a higher cost to do them. And finally, we negotiate with strength with hospitals and specialists to make sure that we carry cost containment to the acute care level. This is what that system looks like. At the middle of this diagram, in the green circle, that's where the employers are located. It's composed of a community of employers with multiple employers and consumers, many of which are the employees and the employers. It uses federally qualified health centers or a similar type of organization that is dedicated to being effective and efficient and also to quality service. And those healthcare centers work with these employers and consumers to make sure that they stay that way. It uses drug bidding. In that green circle, much of the savings occurs. The light green circle is still in the community. It includes all the other primary care providers that are not federally qualified health centers or the equivalent, but they're in the community. It includes local hospitals and specialists as well. Those services are still available and paid for by traditional insurance that the pool acquires. One difference can be that the multi-year funding trust would help to hold down those costs not just for the primary care system in the dark green, but also for all the other services offered in the community, meaning primary care that's not as cost effective, as well as local hospitals and specialists. The umbrella that secures all of this together is using commercial insurance companies that work for the pools. These commercial insurance companies are providing service still, but it's under a better organization that allows all the benefits of the cost containment to go back to the ratepayers in the middle circuit. These insurance pools would also cover all of out-of-region provider costs, as they do now. To create this type of system, who do we need to work with? The short answer is everyone. As employers, we need to work with employees, premium payers, that's the employers, employee unions, local primary care providers, local hospitals, local specialists, local nonprofits that assist our people in getting to those services, the insurance pools that we use, and future insurance pools that may arise, the insurance companies that service the insurance pools, and the state and federal governments that fund Medicare and Medicaid. So what cost elements are addressed? Many of them. More customer responsibility, more competition, benchmarking of primary care, making it efficient, making it affordable, making it effective. Consumer payments by patients that have choice, but also stress the importance of competitive service and effective service. Reduced risk by putting it over a longer period of time, 5 years as opposed to 1 to 3. Creating economies of scale for our primary care system. Improving records and record transfers between various providers. Making the system truly answerable and accountable to the community that's there. And increasing community participation, both by payers and patients, in the actual management of the system. This is that list that you saw earlier from Wikipedia. All the points that were raised in that Wikipedia article about what the elements are of healthcare costs that are addressed by this proposal are in white. The overwhelming majority of those cost elements are addressed in this proposal. This proposal doesn't assume that all these things need to be done. It merely talks about the potential of what can be done and calls for a partnership between the payers, the consumers, and the providers to work together to try to contain costs going forward. So when new things are needed that are going to cost more, that there are at least some potential savings that could be made in other areas to offset those costs, to make sure that the system stays affordable and doesn't reach 33% of gross domestic product. What cost elements? Primary care, 30%. Drugs, 14%. Administrative, 10%. This proposal does not address, at this point, hospitals or specialists, but it does address the remainder, 30 plus 14 plus 10. Total of 54% of the total cost. What are the goals? And these are containment goals. Doesn't mean we're looking to cut the cost by this, but over an extended period of time of 5 to 10 years, it should be possible to work towards reducing the degree of cost in each of these areas. On primary care, the goal would be to cut the cost by 50%. Still provide a very effective primary care system, but work for efficiencies to make sure that we are doing it in an effective manner for quality, but also in an efficient manner. On drugs, to cut the total cost of drugs by roughly 9% versus 16% of the healthcare costs still going into drugs. So that's roughly a 60% reduction in drug costs. Administrative savings, at the very least 2%, and that comes from arbitraging and spreading the risk over a longer period of time. So what do those amount to? 15% of our total costs would be saved in primary care, 9% in drugs, and 2% in administrative costs and insurance costs. That's a total of 26%. That would be our goal for what we should be able to do to be able to divert funds that we're currently paying to other needs in the healthcare system as time goes on. These strategies or other similar strategies can be implemented in part or completely. The parts that we can implement now are pool competition, extended years of premium coverage, bidding of drugs, participation in the cost management of primary care through something that resembles an accountable care organization or a federally qualified health center or any primary care system that offers quality service and competitive pricing. We can negotiate with hospitals and specialists to reduce our rates or keep our costs down. And we can also negotiate terms with insurance companies so that we get the benefits of the savings that we fight for. So this is a call for action. Health costs are increasing 3 to 4 times the rate of inflation. We can't keep absorbing this cost and be competitive in the private sector. And public employers can't keep absorbing the cost and pass budgets. The result is we shift the costs. We insure fewer people. We shift benefits, the cost of benefits, to our employees. And the problem with that is employees making $35,000 a year can't absorb a $22,000 annual family cost for care. Shifting won't work, and ultimately, the burden, if we shift, will be passed on to the federal and state governments who can't afford to pay the cost of the uninsured workers right now. So what does this mean? Without a real effort to control medical costs, employers will not be insuring people. The people will not be able to pay their medical bills in hospitals. They'll be picked up by a federal plan that will be overwhelmed as the employer-insured employees shift more frequently to these federally subsidized programs. And doctors eventually will have fewer customers. All of us, ratepayers, patients, doctors, hospitals, we all need to get together to have a collaborative management system to contain costs. That's the only way we'll survive. So the question for us is, are we willing to collaborate? Can we collaborate? How can we collaborate? Collaborate means that we recognize we all have common interests. We have an interest in maintaining a quality health care system in a way that's sustainable, that is affordable to the people going forward. We all need to have that sustainable, affordable health care system. We all will suffer if we don't come up with a way to make this work. This process is proposing discussions, and they're already underway, with public sector employers in the Upper Valley. Currently, 18 towns and school districts have signed up, major towns and school districts, and we're now approaching the smaller towns throughout the region. It needs to also be addressed by private sector employers as well. We've already had and will continue to have meetings with a variety of people, including the local government center, school care, New Hampshire Insurance Trust, and on the Vermont side, Vermont League of Cities and Towns. We've met with trade unions, employee unions. We've met with BidRx and Trendline. We're setting up tours and reviews at the Health Center in Vermont to look at that example. And we need to meet with the New Hampshire Insurance Department. We've already met with the Vermont Insurance Department. And we need to meet with Upper Valley hospitals and specialists. Many of those meetings have been underway for over a year and will continue to be underway. Meetings have been held with Alice Peck Day and with the Dartmouth Institute, who is in the process of creating a system to redesign, rethink the healthcare system in the Upper Valley.